Hello, my name is Wilson Miskelly, and today I'm going to be doing a head-to-toe assessment for the University of Memphis for the spring semester 2026. Today is January 22nd, 2026, and this is our lovely assistant Asia, and we're going to start with a scan of the room as well as a scan of my supplies. Scan of surfaces, floor, and ceiling. We're going to get started with a skin assessment of the face and head. Before we began the video, for patient privacy, we did a skin assessment of the anterior and posterior chest and abdomen. Overall, we see that the skin color is normal for ethnicity, it's warm, dry, smooth, and intact. We'll move on to an inspection of the head. Overall, we see it's normal cephalic, symmetrical, and aligned along the midline. Inspecting and palpating the scalp, we see that the hair is evenly distributed. It's a natural brown color and it has a coarse texture. We see no evidence of masses, depressions, lesions, signs of infestation, or tenderness. Moving on to an assessment of the temporal arteries, we will palpate them, and they are 2+ and equal bilaterally. We will palpate our lymph nodes, starting with our preauricular, our postauricular, occipital, submandibular, submental, anterior cervical, posterior cervical, and supraclavicular. No tenderness noted with those palpations. Next, we'll do an assessment for TMJ. We'll have our patient open and close their mouth. Okay, there's no signs of crepitus, subluxation, or tenderness noted. We will then move on to the motor function of the trigeminal nerve, cranial nerve number 5. To do so, I'll have our patient clench your jaw and open your mouth against resistance. Motor function is intact. We will move on to the sensory function of trigeminal nerve number 5. So go ahead and close your eyes for me and tell me where I'm touching.
Chin, cheek, forehead, nose.
Good. Sensory function of the trigeminal nerve is intact. Next, we'll move on to facial nerve, cranial nerve number 7. To do that, I'll have our patient close your eyes tight, raise your eyebrows, pucker your cheeks, and pucker out your lips. Smile and frown. Facial nerve, the cranial nerve number 7, is intact. Next, we'll move on to an assessment of the ears. We see that they are symmetrical and aligned bilaterally. We will palpate the tragus and the pinna. We see no nodules or tenderness noted there. We'll move on to an otoscopic exam. To do that, we'll get a look at the auditory canal and the tympanic membrane. Auditory canal is clear and the tympanic membrane is a pearly gray color bilaterally. We will move on to an assessment of the hearing test. To do that, it's cranial nerve number 8, the vestibulocochlear. We will begin with a whisper test. I'm going to whisper 2 words to you, and each year you repeat them back to me.
Dog, cat, orange, apple.
Okay, whisper test is normal with no hearing loss noted. Next, we will do the Weber test. To do that, we will use this tuning fork, place it in the center of your head. You let me know if it's louder on one side or the other.
No.
Okay, Weber test is normal with no lateralization. Next, I'm going to use this tuning fork to do the René's test. To do that, I'm going to place this tuning fork on the mastoid, and then one other place. You tell me when you can no longer hear it on the mastoid, and I'll move it to one other spot. Okay.
Now.
Okay.
Now.
Okay.
Now.
Okay. René's test is normal with air conduction being greater than bone conduction. Next, we'll move on to an assessment of the facial features, the eyebrows, eyelashes, and palpebral fissures. We see that overall the hair is evenly distributed across the face and that the facial features are symmetric. Go ahead and look up for me. The sclera is white, the conjunctiva are pink, and I see no redness, no discharge, and no lesions noted. Next, we will do an assessment of the optic nerve. To do that, we're going to test our patient's visual acuity. I'm going to have you cover your right eye, and you read the smallest line if you can for me.
LTFPH.
Okay, now cover your other eye, and read it again.
LTFPH.
Good. 20/20 vision bilaterally. Next, we will move on to assess for peripheral vision. To do that, I'm going to have you cover your left eye and look straight ahead for me and tell me what number you're pulling up.
1, 2, 3, 4.
Okay, now your other eye.
1, 2, 3, 4.
Okay, peripheral vision is intact. We will now move on to an assessment of the cranial nerve number 3, the oculomotor. To do that, we are going to use our pin light, and we're going to take a look at your pupils here. Look straight ahead for me. Pupils are equal, round, and reactive to light bilaterally, and they're 3 millimeters in size. We're going to test for accommodation and convergence now. Follow my pin light with your eyes only. Okay, accommodation and convergence is normal. That cranial nerve number 3 is intact. Next, we will do a test of cranial nerves number 3, 4, and 6. To do that, we're going to test the 6 cardinal areas of gaze. So follow my fingers with your eyes only. Okay, the extraocular movement is coordinated and symmetrical bilaterally. Next, we're going to take a look at the internal eye structures, and we're going to look for red light reflex as well. Okay, so look straight ahead for me. Okay, red light reflex is present bilaterally, and the retinal arteries and veins show no narrowing, no enlargement, no hemorrhage, no lesions, and no discharge, and the optic nerve has sharp disc margins. Next, we'll move on to an assessment of the nose. We see that the nose is midline and straight. We will go ahead and test for the olfactory nerve, cranial nerve number 1. To do that, we're going to test our sense of smell. So go ahead and close your eyes for me, and occlude one of your nostrils. Okay, what do you smell?
Alcohol.
Okay, now your other nostril.
Alcohol. Candle.
A candle, okay. Good, olfactory nerve is intact. We will palpate the maxillary and the frontal sinuses, and there's no tenderness to those palpations. We will move on to an assessment of the mouth. To do that, we're going to assess the tongue, the lips, the teeth, the gums, the tonsils, the posterior pharynx, the salivary ducts, buccal mucosa, roof of the mouth, the hard palate, and underneath the tongue. We will use our pin light and have our patient stick your tongue out and move it to the right and the left. Structures are normal. The tonsils are grade 1, and there is no swelling, no redness, and no lesions present. Next, we will do a test for the glossopharyngeal and the vagus nerve, cranial nerves number 9 and 10. To do that, I'll have our patient stick your tongue out and say ah. Okay. The soft palate and the uvula both froze with phonation, so that is intact. Next, we will do a test for the glossopharyngeal, cranial nerve the glossopharyngeal. We will have our patient stick your tongue out, and to the left, to the right, and up, and down. Okay? Movements are coordinated and symmetric with no vesiculation. Next, we will move on to an assessment of the neck. To do that, we will palpate the trachea. The trachea is midline, and the neck is supple. We will go ahead and palpate for the thyroid. To do that, we will move the trachea to the left and have our patient swallow, and to the right and have our patient swallow. Okay. The thyroid is non-palpable, and there's no tenderness or nodules noted. We will move on to an assessment of the carotid arteries. To do that, we will start with the left and to the right. Carotid arteries are 2+ and equal bilaterally. We will now auscultate with the bell of our stethoscope for bruits. No bruits noted. Next, we will go ahead and move on to our assessment of the posterior chest. To do that, we'll have our patient stand up, and we'll turn our chair here. We're back facing the camera. All right. So we are looking for signs and symptoms of respiratory distress, such as retractions, tripoding, nasal flaring, use of accessory muscles, cyanosis, or tachypnea. None of those are present. Overall, we see that the chest is symmetrical and with no deformities. We will palpate for chest expansion. Take a deep breath in and out. Okay. We will now auscultate our breath sounds. our diaphragm. Take a breath in with each touch. Breath sounds are clear and equal bilaterally. Next, we will test for bronchophony. For that, I will have you say 99 with each touch.
99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay, we will now do egophony, so I'll have you say E with each touch.
E, 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 E.
Okay, now we will test for tactile fremitus. To do that, I'll have you say 99 with each touch.
99, 99, 99, 99.
Okay, now we will do whisper pictoriloquy. For that, I will have you whisper 99 with each touch. Good. Now we will percuss at the intercostal spaces. And resonance is noted throughout. We will go ahead and have our patient stand up, and we will turn you around to face the front. We will do an assessment of the anterior chest. Again, we see that the anterior chest is symmetrical with no obvious deformities. We will go ahead and palpate for chest expansion. Go ahead and take a deep breath in and out. Chest rose symmetrically. We will again listen for breath sounds. We'll have you take a breath in with each touch. Breath sounds are clear and equal bilaterally. Next, we'll move on to an assessment of the heart sounds, starting with the aortic valve on the right sternal border at the second intercostal space. Then the left sternal border at the second intercostal space, the pulmonic. And then Erb's point at the third intercostal space on the left sternal border. The tricuspid valve on the left intercostal space at the fourth intercostal space at the left sternal border, and then the mitral valve at the left midclavicular line at the fifth intercostal space. This is the point of maximal impulse, and I feel no abnormal pulsations. Normally we would listen to that for 60 seconds, but for our purposes, the heart rate was normal sinus rhythm and a rate of 90. Overall, we heard S1 and S2 is noted with no extra sounds noted, no bruits, no gallops or murmurs noted. Now we will listen to these areas again for bruits with the bell of our stethoscope. Starting with the aortic, pulmonic, Erb's point, tricuspid, and mitral. No bruits noted. We'll go ahead and have our patient lay down over here, and we will assess for JVD. Okay, we are looking at the sternocleidomastoid here, and we are palpating and inspecting. We see no abnormal pulsations. The jugular vein is flat. We'll go ahead and have you lay all the way flat here. And again, turn your head that way, and we see no heaves or lifts noted. We will go ahead and listen to those heart sounds again with our patient laying flat, starting with our diaphragm, starting with the aortic, pulmonic, Erb's point, tricuspid, and mitral, and with our bell, aortic, pulmonic, Erb's point, tricuspid, and mitral. S1 and S2 are noted with no extra heart sounds, no murmurs, no gallops, and there are no bruits noted either. Took these off, but we are going to assess for bruits in the abdominal arteries, starting with the aorta, the renal arteries, the iliac arteries, and the femoral arteries. There are no bruits noted throughout. Using the diaphragm of our stethoscope, we will also take 4 vowel sounds in all 4 quadrants. Vowel sounds are normal active. We will go ahead and percuss our patient's abdomen. Tympany is noted throughout with dullness over the liver and tympany over the spleen. We'll go ahead and palpate our abdomen now. No abnormal masses or tenderness noted. The abdominal contour is flat and symmetrical. We will palpate the liver and the spleen, both of which are non-palpable. We'll have our patient go ahead and sit up again. And we'll sit with our back facing the camera. We're going to check for CVA tenderness. To do that, we're going to percuss the lower back. You tell me if you have any pain.
No. No.
Okay, no, CVA tenderness is negative. We'll go ahead and have you face the front. We're going to move on to an assessment of the upper extremities. To do that, we are going to look at the fingers, the wrists, the elbows, and the shoulders. Our inspection and palpation of these joints our inspection shows that there is no redness, no swelling, and no deformities. Our palpation shows that there's no crepitus, no nodules, and no tenderness noted. We will assess for capillary refill, and capillary refill is less than 3 seconds. Our radial pulses are 2+ and equal bilaterally, and we will go ahead and start some range of motion. So you just mimic my movements with your hands. We're going to start with flexion, extension, hyperextension, abduction, adduction, and thumb opposition. Good full range of motion noted there. We'll do our wrists now. We'll do flexion, extension, hyperextension, ulnar deviation, radial deviation, and rotation. Good. Full range of motion noted in our wrists. We'll move on to our elbows here. We will do flexion, extension, and hyperextension. Good full range of motion noted in our elbows. Now we will do shoulders. For this one, we will do flexion, extension, hyperextension, internal rotation, external rotation, abduction, adduction, and circumduction. Good full range of motion noted in our shoulders. We will go ahead and do our strengths. We will start with grip strength. Squeeze my fingers. 5 out of 5 strength. Go ahead and push against me and pull against me. Good. 5 out of 5 strength there. And now we will do our shoulders. Push against me and pull against me. Good. 5 out of 5 strength noted in our shoulders. We will move on to an assessment of the accessory nerve, cranial nerve number 11. To do that, we'll have you shrug your shoulders against resistance. Good. That nerve is intact. We'll move on to some cerebellar coordinations. To do that, we just mimic my motions again. We're going to start with finger opposition. Good. We will do supination and pronation of the hands, some hand flip-flops. Good. And then we're going to do the finger-to-finger test. Go ahead and touch your nose and my finger. Nose, finger, nose, finger, nose, finger. Good. And now the other hand. Nose, finger, nose, finger, nose, finger, nose, finger. Good. Now we're going to do some stereognosis. To do that, I'll have you close your eyes for me. Now I'm going to have you identify some objects. Hold out your hand for me. What is this?
A key.
Okay. And what is this?
A pen.
Okay. Now your other hand. What is this?
A pen.
And what is this?
A key.
Good. Stereognosis is normal. With your eyes still closed, we will go ahead and test for graphesthesia as well. So hold out your hand. I'm going to draw 2 letters in your hand. You let me know what they are.
T. S.
Okay. And your other hand.
T. S.
Good. Graphesthesia is normal. We will move on to an overall skin assessment of the extremities. We note that the skin color is normal for ethnicity. It is warm, dry, smooth, and intact. We will now move on to some sensory function of the upper and lower extremity. We'll do light touch first. I'll go ahead and have you close your eyes, and you tell me where I'm touching you.
Left leg. Left arm. Right leg. Right arm.
Okay. Light touch is intact. We will move on to vibratory sensation. To do that, you tell me if you can feel vibrations in these locations, starting with the radial prominence.
Yes.
Okay, the ulnar prominence.
Yes.
Okay. Radial prominence
Yes.
and ulnar prominence.
Yes.
Good. The medial malleolus
Yes.
and on both sides.
Yes.
Good. Vibratory sensation is intact. Next, we will do our deep tendon reflexes, starting with our brachioradialis. Can I see your hand? Okay. And we'll do our brachial and our triceps. Our patellar. Our Achilles. And the Babinskis. All of these are normal, and we will move on to our assessment of the lower extremities and the joints they're in. We will do an inspection and palpation of the toes, the ankles, the knees, and the hips. Overall, our inspection shows that there is no deformity, no swelling, and no redness. We see that in our palpation there is no crepitus, no nodules, and no tenderness present. We are going to do some capillary refill in the toes. They are less than 3 seconds bilaterally. We will now assess for the dorsalis pedis pulse on both sides. It's 2 plus and equal bilaterally. Now the posterior tibialis. Okay, 2 plus and equal bilaterally. Now we'll move on to some range of motion in these lower extremities. Follow my motions as best you can with your toes. We will do flexion, extension, hyperextension, abduction, and adduction. Good. Full range of motion noted in the toes. Now we will do the ankles. We will do plantar flexion, dorsiflexion, eversion, inversion, and rotation. Good. Full range of motion noted there. Next we'll move on to our strengths. I want you to push down on me like a gas pedal and pull up, and then gas pedal and pull up. Good. 5 out of 5 strength there. Now push against me and pull against me. Good. 5 out of 5 strength there, and push out and pull in. Good. 5 out of 5 strength there. We'll go ahead and have you stand up, and we will do our range of motion in our knees. To do that, we're going to start with our right leg, and we're going to do flexion, extension, and hyperextension. Good. Full range of motion. Now we will do flexion, extension, hyperextension. Good. Full range of motion there. Now we'll do our hips, starting with flexion, extension, hyperextension. We will do internal rotation, external rotation, circumduction, adduction, and abduction. Good. Now we'll do the other side. We will do internal rotation, external rotation, flexion, extension, hyperextension, and then we'll do adduction and abduction and circumduction. Good. Full range of motion noted in the hips. Have our patient face away from us. We're going to do a spinal assessment. Here we see that the spine is symmetrical and aligned. We'll have our patient lean forward slightly at the hips. Good. We see no scoliosis and no kyphosis noted. Have you stand back up. Now we're going to do some range of motion in the spine. For this, we're going to have you lean forward for flexion, and then extension, hyperextension. Good. Now we will do lateral and lateral extension. Good. And then now we will do rotation, just at the hips there. Yeah. And then other side. Good. Full range of motion noted in the spine. And there's no tenderness. Everything's symmetrical there. We will have our patient go ahead and stand off to the side there. And you're going to walk towards me. Good. And turn around and walk back heel to toe. Good. And now you'll come back here in the middle. And you're going to close your eyes with your palms up towards the ceiling and raise them up all the way up. Good. No swaying noted. Romberg sign is normal. And now I'll have you stand on one foot and hop them down. Okay. And now the other foot. Good. This completes my head to toe.